Recently I had a similar case, but a young woman who's 45 years old, who I started on dasatinib frontline. She had a complex karyotype, not isochromosome 17. And then her doctor at home said, you go for transplant, you have a very bad features. So I started on dasatinib. I did a marrow at 3 months, and she was in CCYR, all things gone. So I monitored her, so I was more reassured that there's nothing missing. But
You answered my second question, because I was curious what folks, James, what would you do if this resolves? So the chromosome abnormality goes away and you get a good response by 6 months that you're satisfied with, saying they're responding. Does that change your transplant direction?
So I think for this patient, obviously the high-risk features observed at the time of diagnosis will kind of indicate that this is a patient that we're going to follow very closely. And we're definitely shooting for a 60-year-old patient like this to get them into an MMR by 18 months. I think for us, if they achieve those milestones, transplant isn't something we would pursue at that time, but we would definitely be doing more frequent bone marrow biopsies in a patient like this and be looking for some of those other cytogenetic abnormalities to resolve entirely.
so James, if this patient did not achieve an MMR, you will take her for transplant?
No, not necessarily, but I think that that person who's not achieving an MMR by 18 months is a person who we're going to follow more closely, observe them more closely, consider marrow and repeat genetic testing at that time. But I would not take a patient to transplant with a PCR less than 1%.
Maybe just shine a little light on that subject for a minute, the importance of cytogenetic complete remission, and maybe in this case, clearing the clonal changes. But how long do we wait for MMR? Because I think we all would recognize that MMR has sort of not become more prominent, but perhaps less prominent in guidelines with regards to timing and expectation. And I know there is some data looking at when does a patient really face increased risk having not achieved a major molecular remission. Maybe it's closer to 24 months. Because I get asked that patient routinely by colleagues and patients. Well, I'm on the green, but I'm not in the hole. And I'm in a deep remission already. Do I have to change therapy, raise the dose, simply because they haven't had an MMR, say, between 12 and 18 months? Maybe they're just shy. I don't know how you guys feel about that.
Our practice has been, as long as your PCR below 1%, doesn't matter. Okay. You stay on treatment, you don't miss, you don't skip medication because you want to progress, but I keep monitoring, I will not go for transplant. Now, for these specific patients, the slow response, as you highlighted it, if somebody was 45, I would have switched therapy to second-gen TKI, not keep on imatinib therapy. But in this case, if you come to see me tomorrow with 1%, I will not do anything. I will make sure he's monitored and highlight compliance.
I think one of the important things to remember too is that when we reference these studies, these trials took place in what is not really the real world scenario. And I think that all the data that we refer to is captured from trials where patients were monitored very closely. And I think that this really highlights the importance of close monitoring in these patients, which is not always accomplished in the community. So I think that that every 3-month PCRs for this patient is something that is really critical to their management.
Yeah, I tend to sort of think somewhere right in that space where we believe that cytogenetics are really, really important, and achieving a complete cytogenetic remission remains almost the gold standard, even in a molecular world. And the MMR may be becoming less and less important if people, when you hit it, it's nice, it predicts some stability. It's not likely that people leave an early MMR to go into blast phase or accelerated or even die with their CML. So from my perspective, I do follow them. I'm not typically switching TKIs at 18 or 24 months if people are around an MMR but just haven't hit it. If they're tolerating it well, if they're being compliant, those are people, James, I follow closely. I'm pretty religious about every 3 months for most of those people that are still borderline and have never hit an MMR. Because we're all afraid of case number 2, right? We're all afraid of this great early deep response that blows up and becomes accelerated and or blast phase and presents out of the blue feeling poorly. So I do follow pretty carefully patients that haven't achieved every milestone, but rely on it less as being a true goal.
Just outside this case about monitoring, I want to get your opinion on a case I had. So a woman who's 50 years old, had CML, had dasatinib frontline, had a CMR undetectable levels for 6 years. I stopped her TKI and monitored her. Regular monitoring, every 3 months PCR. undetectable. Okay, and then in March this year, she had a for on-time PCR showing positive at 0.1.
How long after
2
stopping?
years.
2 years after
2
stopping.
years after stopping. 0.1% at March. I told her to come back see me. She comes back with a count of 50,000 within a month. I repeat the PCR. She's coming to see us at Anderson just to repeat her PCR testing because it turned to be positive at one time point. 50,000, repeat the PCR 100%. She's lymphoblast phase.
This is the case you need to report to the NCCN per the guidelines because this is an unusual outcome. And
Correct. And they keep saying only 6 months. If you pass 6 months, you don't have a relapse, you're done, no progression, no transformations whatsoever. And here the case out 2 years having transformations. So we should be very careful with the monitoring for this patient. It does still happen. It's rare, but it's not.
Yeah. The good news is the NCCN guidelines, although I know the data says there's optimism around if you pass 6 months, things are good. The monitoring still needs to happen, and it needs to happen meticulously, monthly for a year, 6 weekly for the second year, quarterly in the third year, because we still haven't uncovered all the potential nuances of treatment-free remission or treatment cessation.
I'm working with my fellow on a review for TFR. And in fact, in all the paper published, CML and others, there's no transformation. They will say, you can stop therapy, you relapse, you can resume TKIs, and no transformation. And here a case of transformation, because these are off the outside the follow-up or the outside trials.
Your case is an important one too, because in addition to telling people they may have aches and pains if they stop their drug, and in addition to saying it's going to be a hassle, you're going to have to come back frequently because we are going to monitor you monthly and then every 2 months and then quarterly for many years. We need to tell people that it is possible that your disease will change, and it will go from undetected or nearly undetected to a more advanced phase. Can exist because we know that it can exist while you're on a TKI. So certainly it has to be able to exist when you're off it. And I think those types of risks need to be fully discussed with your patients prior to discontinuation.
I think we've learned a lot about monitoring. We need to look for clonal evolution. Unfortunately, clinical trial data would tell us that even when watched, the Simplicity study, which has been published in a few different iterations, shows that many patients don't get cytogenetic testing or molecular testing within 12 to 18 month timeframes. So monitoring is key, and then especially in treatment-free remission, and guidelines give us the roadmap, and we'll hope for good news on that case.
Well, I started on blinatumomab and she's already in CR.
Very good.